Hi everyone, thanks for listening to my presentations. Today I'll be talking about hyponatremia, meaning low level of sodium in the blood. Okay, and I'll be going through causes, signs, and symptoms. Let's go. Okay, we might ask ourselves, or someone will ask us, of what importance is all this headache about hyponatremia? Oh, yes, it's pretty important. Okay, there's what we call tonicity, and that is the ability of solution to alter the volumes of cells by changing their water content. In hypotonic environment, cells gain water and swell up, and that will be the situation with hyponatremia, and we don't want that. Okay, that's why this topic is pretty important. Remember, from the elementary or high school biology, depending on where biology starts with you, we were taught that cells will form tissues, tissues will form organs, organs will form the various body systems, and all the systems put together will form the body or the whole human being. Therefore, we are very much concerned about the environment where the cells are formed, because in the same elementary biology, we were taught that a cell is the basic unit or fundamental unit of life. If a cell is that important, and cells will congregate to form tissues and then organs and systems and who we are, then it is not out of place for us to dedicate a lot of time to know the medium where those cells are. In hypertonic environment, cells will lose water and shrink. We don't want that either, but that is for another day. So for today, we'll start talking about hyponatremia, particularly in hypotonic environment where cells can gain water and swell up. We don't want that. Okay? So this topic is pretty important. Still on what importance are we going to derive from studying or knowing more about hyponatremia? In an isotonic environment, cells will remain unchanged. No, they will not change in size, even with osmotic fluid transfers. And that is exactly where we want them to be. That's where we want cells to be. We want isotonic environment. So we are uncomfortable with hyponatremia or with hypotonic environment. And we should check our elementary books or notes. We should brush over what osmosis, osmolality, diuresis, diuretics, ADH, syndrome of inappropriate antidiuretic hormone, diabetes mellitus, and of course diabetes insipidus, central or peripheral, and so on. Because in the course of this presentation, before we reach the end, we will touch all these subjects. Okay, ADH. Because we'll come across ADH a lot in the course of this presentation, I will take the time now to define. ADH is antidiuretic hormone, otherwise known as arginine vasopressin, or some call it vasopressin, others call it ADH. It is synthesized in the supraortic nuclei of the hypothalamus and stored in the posterior pituitary. Actually, there are only just two hormones stored at the posterior pituitary, ADH and oxytocin.
And that is why oxytocin is another hormone with antidiuretic effect. Yeah, brothers and sisters. ADH is a key factor in blood pressure regulation and also in osmotic balance, and now in sodium homeostasis. And that is why we will mention ADH a lot in the course of this presentation and subsequent ones on hyponatremia and even hyponatremia. ADH is also a key player in kidney function. In tonicity homeostasis, hyperosmolar state will trigger the release of antidiuretic hormone. Then, the antidiuretic hormone will act in the kidney to increase water reabsorption to balance the medium. In hypovolemia or volume depletion, ADH will sense the drop in blood pressure. Then, it will increase water reabsorption in the kidney and also exert its vasoconstrictive effect on blood vessels. And with vasoconstrictive effect on blood vessels and increased water reabsorption in the kidney, there will be increase in the blood pressure. Lastly, in hypovolemia, ADH will be secreted even in hyperosmotic states. However, hypovolemia or hyperosmotic hypovolemic state will inhibit ADH secretion. Okay, now more about the tonicity. The concentration of sodium and other solutes will determine the tonicity of the extracellular fluid, which means solutes like sodium, glucose, chloride ion, bicarbonate ion, plasma proteins, and so on will all play roles in determining the tonicity. So we might be dealing with a hypotonic situation, isotonic, or hypertonic. Now, all we want is isotonic extracellular fluid. And as far as sodium is concerned, the value of sodium that will give us that is anything between 135 to 145 milliequivalent per liter. That is, if all other solutes are not in excess also, okay? But in hypotonic ECF or hyponatremia, the value of sodium will be low, lower than 135 milliequivalent per liter. The severity of the symptoms will depend on how low the sodium level is and for how long and for how quickly the value of the sodium drops, okay? But in certain situations, even when sodium level is low, there will be no hypotonic ECF. In that case, we might be dealing with hyperglycemia, hyperproteinemia, or hyperlipidemia. Okay, hypertonic ECF, on the other hand, when it is all about sodium, it means the value of sodium will be high, and anything greater than 145 milliequivalent per liter will be a big concern. That will be for another day. As a matter of fact, some literature will give you anything greater than 147 milliequivalent per liter. But we all know, once it is greater than 145, then we have the concern. But that is not our goal for today. The goal for today is anything less than 135 milliequivalent per liter, and we want to achieve the isotonic state of 135 to 145 milliequivalent per liter. Okay, now hyponatremia. There can be hyponatremia without hypotonic ECF, like I've explained just in the last 1 minute. In that case, when we're dealing with hyperglycemia or pseudohyponatremia from severe hyperlipidemia or hyperproteinemia. Okay, now,
there's an entity known as hypotonic hyponatremia. Okay, and what could be responsible for this? There's low level of tonicity and there's low level of sodium. And what is causing this? It could be as a result of normal antidiuretic hormone. Okay, in that case, there's decreased dietary salt intake. If ADH is not responsible for this, then what? There's decreased salt intake in alcoholics, in potomania. Potomania, particularly beer potomania, is a condition with hyponatremia due to excessive beer consumption. Well, I will delve into that in details in another day. Also, in tea, toast diet, cultural belief practices by some. For example, some tribes in some parts of the world believe that a pregnant woman should not take salt while pregnant. Yeah, I've heard that before. Okay. Hyponatremia could be as a result of excessive loss of sodium. For example, exercise. Exercise induces hyponatremia. And that is why the drink they will give you when you are an NFL star, an NBA star, soccer star, or you're an athlete running 100 meters or 400 will be salt containing. Psychiatric disorders like primary polydipsia due to psychosis. This individual just decides to be drinking and drinking water, okay, then diluting the extracellular fluid. Normal suppression of ADH, but abnormal dilution. And that will happen in the face of chronic renal failure or end-stage renal disease, or someone using diuretics, and then leading to loss of sodium. Okay, if it is not normal ADH with all those points that I've mentioned earlier, it could be as a result of increased ADH secretion leading to impaired urine dilution. In that case, we'll be dealing with decreased blood volume, and the volume depletion with hypovolemic hyponatremia will occur. Okay? Here, heart failure with hypovolemic hyponatremia can occur, and of course, cirrhosis with hypovolemic hyponatremia could also occur. It's also found in Addison's disease. Here, there is increased ADH secretion meant to retain water, leading to impaired dilution. Okay, in case of euvolemic hyponatremia, normal volume of fluid, but there's decreased sodium level. That could be found in syndrome of inappropriate antidiuretic hormone, in meningitis, and you know complications of meningitis will include SIADH itself, in cancer, in AIDS, in certain medications, surgery, in severe hypothyroidism, secondary adrenal insufficiency, and certain hormones like oxytocin and DDAVP. Also in nephrogenic syndrome of inappropriate antidiuretic hormone. Osmolar dysregulation could be a problem. And let me explain that. Osmolar is centered in the hypothalamus that controls the osmolality of the ECF. And the dysregulation of that center could give us the problem we're dealing with right now. But that has genetic undertone and could also be found in pregnancy and chronic illness. Also possible could be cerebral salt wasting. Okay, Patho here will go thus. There's increased water intake or increased water absorption. Okay, then hypotonicity of the ECF will set. Release of ADH will be suppressed, and there will be a drop in test. Okay, because already we are dealing with hypotonic situation, right? So you will not be thirsty to drink more water. Then the release of ADH that is suppressed, that is ADH level is not risen, is not being released, and there's no test, will affect both the osmoreceptors that will respond to sodium level and baroreceptors that will respond to status of the circulation. In the kidney, the ascending loop of Henle and distal convoluted tubule will help us. Doing what? They will help in reabsorbing salt without water reabsorption. Okay? So they'll be excreting water with less electrolyte in it. So water intake will be proportional to the urine volume excreted. In hyponatremia with more water and less sodium, ADH is not suppressed. There is an impaired renal excretion with water retention and decreased loss. In primary polydipsia, the large amount of water ingested has overcome the above mechanism even with normal level of ADH. Okay, what are the classes of hyponatremia? Already we have a problem, right? With increased water in and decreased water out, then leading to dilution. The difference here is then we have to excrete, water without electrolyte. In other words, excretion of electrolyte poor water, so as to keep more electrolyte in the system and send out more water. Then we can have these three classes of either hypovolemic hyponatremia, low level of sodium and low level of volume, right? Or normal volume, euvolemic but low level of sodium, hyponatremia. Or high volume and low sodium, hypervolemic hyponatremia. We'll go into details of each of these later on. Okay, what are the possible clinical features? The clinical features will depend on the level of sodium, whether it is acute or chronic. Okay, for example, acute phase and the level of sodium below 125 milliequivalent per liter will give us nausea and vomiting. And this could be life-threatening because it could be associated with cerebral edema. Okay. There will be malaise, headache, lethargy, confusion, seizures, coma, particularly hyponatremic, encephalopathy could occur, and death could occur. The individual could die. Or if he or she is not dead, if there is no appropriate management on time, there might be permanent neurological damage. But if the sodium level is between 115 to 120 milliequivalent per liter, we stand the risk of pulmonary edema, respiratory arrest, and death. In chronic hyponatremia and below 120 milliequivalent per liter, it might be asymptomatic. Remember, I've said it's chronic, right? And even when it is symptomatic, it might be non-specific. I might be dealing with nausea, vomiting, dizziness, fatigue, gait disturbances, forgetfulness, and confusion. So in that elderly man having confusion and forgetfulness, it's not all the time that it will be dementia. No. It could be hyponatremia, could be hypoglycemia, could be hypothyroidism, could be vitamin B12 deficiency, could be anything, Okay, we just have to have open heart, right? There could be lethargy, muscle cramps, less seizures, or coma, unless there is an acute exacerbation of the hyponatremia. Falls is very common in elderly, and they will likely come down with fractures. Remember, osteoporosis are setting, right? And now they are falling more frequently because of gait disturbances and confusion and forgetfulness. Okay, so it's better we help them. But good thing about that is because it is chronic, there will be less seizures, less coma, unless they have acute exacerbation. Mortality increases as sodium decreases from 135 to 120, but below 120 milliequivalent per liter, something will happen. The mortality will decrease, paradoxically. Okay, severity, usually very severe cases will be secondary to medications. Mild to moderate cases may become life-threatening later on because of certain underlying causes. In cases that could be attributed to renal failure, heart failure, and liver cirrhosis, then there may be life-threatening conditions, even with mild to moderate stages. Okay, premenopausal and young children. In acute postoperative conditions, there will be decrease in sodium, and clinical features could progress from headache, nausea and vomiting to respiratory arrest. There may be cerebral edema and cerebral herniation. Then we begin to wonder, is there a hormonally mandated drop in the degree of osmotic adaptation? If somebody will supply the answer. Okay, before rounding up, as per this presentation today, I need to delve into osmotic demyelination. The correction of hyponatremia should be done slowly, but when someone inadvertently or deliberately rapidly corrects hyponatremia, then that can cause osmotic demyelination syndrome or central pointine myelinolysis, as formerly known to be. Puns will be spared here. But one interesting thing here is that the symptoms will start at 6 days after the treatment. In other words, you will not be the one to detect the symptoms right there that day. The patient might have even be discharged home, and then the family members will have to call 911 after some days. It may be irreversible, but you can try to treat with gradual lowering of the serum sodium. And with that, I've come to the end of the first part of the presentation on hyponatremia. We will move to the next part, which will be about the diagnosis. You won't believe it. We will have a lot to go through when it comes to the diagnosis of hyponatremia. I mean, definitive diagnosis. And then we'll move to the treatment. And I've laid the foundation for the treatment right now that we will never correct very rapidly, or else we'll enter into another problem. Thanks for listening. Remember to share, remember to subscribe, and you are free to leave comment on my channel. I appreciate that.